Hey folks, I'm Dr. Jeff Williams with Creekstone right here in Amarillo, Texas, and I am your host for the Chiropractic Forward podcast. It's still in its infancy, but it's looking good. I'm enjoying doing it so far. Welcome to this week's edition. This week's entry is going to be a little more geared towards chiropractic practitioners than it will be to potential patients. That is, unless you're a patient that's just a little bent towards learning more about practice protocols, and I just don't know very many of those types of patients. I can see where maybe a patient is interested in this week's video if they feel they've received poor treatment in the past. You know, I guess I could see it then, but most patients probably aren't going to be interested in the video this week, and that's okay. We'll have something for you probably next week. Have you ever been in practice, especially in the early years, and just wondering if you're doing things right? I mean, they taught you how to diagnose, they taught you how to evaluate and adjust patients, but what about all the gaps in between? Did you get it all? And if you got it, did it stick? Did you retain it? Did you receive it and understand it? And are you using it? Well, we all have questions about certain issues. If you aren't always learning and asking yourselves questions, then I'd suggest that you start. I believe that's how we grow. In this video, we're going to try to help answer some age-old questions that many chiropractors get out of school not necessarily knowing the answers to. We're going to cover recommendations on how often, what, why, and how for your practices. It should be interesting for most of you, at least that's my hope. So let's buckle up. There's a lot of information here, so we'll try to make it fun and relatable. Many of us tend to wander around on our own islands for years without any sort of mentorship or guidance. If I'm being honest, and I am honest, I was that way myself until about 11 or so years ago. That's when I finally decided to start paying attention. In fact, there's still times I find myself researching the latest standards of practice and guidelines just to make sure I'm not an outlier in my profession without even realizing that I'm an outlier. It can happen. Healthcare tends to change so quickly that it's a scenario I assume occurs more often than we might think. This sort of information can admittedly be monotonous and can make your eyes bleed if you're reading it and you keep reading it too long. Some people love to dive into long text and technical terms, but I'm guessing that most of you do not. That's why I'm offering it in different forms here. Different people communicate in different ways, right? Some prefer email, some prefer text. I like videos, while other people, they prefer blogs. There's podcasts, there's Reddit, and all kinds of things now. It's all a part of communicating in the best and most effective way possible. And with this in mind, I offer you this information in blog form, right here in a YouTube video. I offer it in the Chiropractic Forward podcast, all in the hopes that you guys and gals out there can digest it and maybe even receive it rather than just simply taking note of it before you move on to something else. The impetus for this week's information comes from a blog I read that was recently published on the American Chiropractic Association's blog. Now, you can find that blog at acatoday.org/blog. The blog was posted December 28th, 2017 and was titled Research Review, Clinical Practice Guideline, Chiropractic Care for Low Back Pain, and was submitted by Dr. Sean Thistle. Dr. Thistle is the founder of RRS Education, which is a continuing education company providing weekly research reviews, much like we do right here on my blog, on YouTube, or as a part of the Chiropractic Forward podcast. I've used Dr. Thistle's article here as the template and simply overdubbed and commented on it as I went through it. So in the article, Dr. Thistle reviews a research paper called Clinical Practice Guideline, Chiropractic Care for Low Back Pain. The lead author and researcher for the paper was Dr. Gary Globe. This guy's got a lot of initials after his name. For example, he has a master's in business, a doctor of chiropractic, and a PhD. The paper was published in the Journal of Manipulative and Physiological Therapeutics in Volume 30, Issue 1 in 2016. And basically, we're doing a review of a review. So you might wonder, why is that even necessary for me to do? Well, I feel it's necessary because I believe that my calling is to take more difficult or more boring concepts, terms, and ideas and strip them down into a very understandable and a very palatable form. A transfer of information, if you will. So hopefully I can get that information distributed to folks that need it. If we just left it at this blog, I assume that the people that really need the information probably won't get it. In other words, the people that read the American Chiropractic Association's blog they've probably already familiarized themselves with a lot of this stuff. However, people that do not read their blog likely don't keep up with chiropractic research either. They're probably not involved with their state association. They probably don't even crack open a dynamic chiropractic from time to time. If they're not involved, then they're just not usually involved. They may be outliers in the profession without even knowing it because they've likely never been exposed to this sort of evidence-based information. And I'm hoping that that's where I come into the picture. First, why would chiropractors be interested in guidelines of any sort? Isn't it easier to just kind of do what you want to do? Well, I would share with you that a frustrating part of our profession for me personally is that there seems to be no standardization that's being widely followed or respected by chiropractors as a population. Some practitioners in chiropractic may think that's a great thing and that that's what is unique about chiropractic and makes it special. I'm of the thought that it's a good thing when you go to a practitioner of any style and you can feel comfortable knowing there are some professional standards of care being followed by your caregiver. It's when practitioners haven't educated themselves or have not at least been somewhat in tune to what's going on in their profession that they may start to be considered an outlier and can run the risk of getting themselves into some sort of trouble professionally. And nobody wants that. So let's be clear. Following guidelines does not mean that the practitioner has no autonomy or that there's no professional decision making going on. They're just that. They're guidelines, general guidelines that not only help your decision making process, but also give you something to refer to should there be any questions down the road about your treatment plans or your protocols. And I call that standing on solid ground. When you have so many webinar and seminar folks trying to scare chiropractors into buying their courses and marketing to them by triggering their fear of either being sued or jailed if they don't buy, well, standing on solid ground is always a bit liberating. Now, be honest here. How does it look when one chiropractor tells the patient that they need to be seen 55 times this year, and then just a week or two later, the patient goes for a second opinion with a chiropractor, and they say the standards of practice require 18 visits over the next 2 months or so for the same issue? Of course, that reflects poorly on the first chiropractor. But wouldn't you agree that it also reflects poorly on chiropractic in general? I'm in no way saying that there's not conditions requiring 55 visits, so don't send me any hate mail. I'm simply using a generalized example here and fictitious numbers, but I think you get my point. I've always felt that treatment should have a start, it should have a finish, it should be responsible and smart recommendations, and upon completion should enter the maintenance phase. If we aren't giving good recommendations, then we simply aren't doing our job. But it's also my opinion that if you're not staying on top of research and current standards of practice, then that also means you're not doing your job. Now that we talked about standards of practice and guidelines, let's dive into the research and the guideline summary. Here's why they did it. Everyone should know by now that low back pain is the leading cause of disability around the world. Research has continued to show over and over that chiropractors are highly effective when it comes to low back pain. Even traditional chiropractic haters at this point mostly concede the fact, whether they like it or not, we are effective. The goal of this research project seems to be focused on providing some sort of standardization and guideline protocols, especially for an easier and smoother transition into an integrated medical setting out there in the healthcare world. The project focused on nonspecific low back pain. And here's how they did it. The authors underwent a comprehensive search of the literature. They found 270 relevant articles. After screening those articles, 18 were accepted for the paper. Of the 18, 16 of the papers were ultimately accepted as being of high quality. Here's where we get into the thick of it. They break their points down into the following categories: general considerations, informed consent, severity and duration of conditions, examination procedures for low back pain, treatment frequency and duration, initial course of care for low back disorders, reevaluation and reexamination, benefits versus risk, contraindications and cautions, and chronic pain management for spinal disorders. There's 10 of them, and we're going to go through all of them, but we're going to try to have fun. Let's dive into them right now a little further, point by point, and try to make some sense of it all. Let's start with the category general considerations. If a patient gets chiropractic treatment in the acute pain phase, they usually have full recovery of the complaint. Even though they may have full recovery, recurrence of the pain can still happen. It's common. If not treated properly in the beginning, it could turn chronic with increased disability. Practitioners at all times should be mindful of red flags and yellow flags. In case you don't know what a yellow flag is, they are usually associated with chronic pain or disability. Some examples may be negative coping strategies, poor self-efficacy beliefs, fear of avoidance behavior, and distress. Yellow flags. And that was according to an article in Dynamic Chiropractic dated November 30th of 2002, volume 20, issue 25, and written by Craig Liebenson, DC. Patients with high yellow flag scores should not be labeled with an injured back. For example, telling the patient they have a ruptured disc might not be the best idea. Your treatment should reduce dependency on medication and encourage active treatment rather than passive treatment, and should include self-treatment protocols. The authors of this paper feel that the goal of chiropractic should be improving the patient's functional capacity as well as educating them to accept responsibility for their own health. Ooh, that's a tough one. Informed consent, next category. Chiropractors often get into trouble because they lack a proper informed consent procedure. Basically, informed consent is communication between your office and a patient that results in the patients giving you authorization for treatment. An informed consent should include a clear explanation of the diagnosis, of your examination, and what you propose to do as far as your treatment. This should include treatment options and possible risks involved. If the person appears to be of sound mind to perform an informed consent, you've satisfied the recommendations, assuming they have no further questions. Next category, examination procedures for low back pain. While there's no limit to what the examination can include, there should be a minimum at least. So there should be a health history, an examination that includes range of motion, or orthopedic tests and or neurological testing, and further diagnostics when indicated. Those further diagnostics may be something like lab tests or further imaging. The report says that range of motion should not be used to determine a person's functional status, but can be used as part of the exam to assess regional mobility. As part of the exam process, they don't recommend routine imaging for diagnostic tests in cases of nonspecific low back pain. Now, with that being said, if serious pathology is suspected or if someone's having neurological issues associated with it, then of course further diagnostics would be appropriate. While the authors are not proponents of regular imaging, MRIs are indicated when the low back complaint is associated with symptoms of stenosis or radiculopathy. Another condition in which a practitioner may consider getting more imaging would be when the patient hasn't responded to a reasonable, responsible, short-term conservative protocol, or if you have reason to suspect something else is going on, something like spondylolisthesis, for example. Okay, we're getting right through this. Next category, severity and duration of conditions. This is really a simple section, but it can cause a lot of confusion by those that have just never had the information or have seemed to have forgotten it. An acute complaint refers to something that has been experienced for less than 6 weeks or 1.5 months. A subacute symptom has lasted between 6 weeks and 12 weeks. Another way of saying that is a subacute symptom has lasted between 1.5 months and just under 3 months. A chronic condition is something that has lasted at least 12 weeks or 3 months. If it's gone longer than 3 months, it's chronic. A recurrence means that it's the return of a symptom that is suspected to be similar to the original complaint. So that was easy, right? Okay. Next category, treatment frequency and duration. The authors indicate that most patients respond to your care, but that the treatment frequency and duration may change depending on the patients themselves. They may have other issues, including red and yellow flags that extend or alter in some way the duration or the frequency of your treatment. Again, the practitioner must always be mindful of the red and yellow flags. The paper suggests that the effectiveness of care should be evaluated both subjectively and objectively during or after each course of care. So, in our office, for example, we use the functional rating index every single day upon the patient's arrival. We also use outcome assessment testing questionnaires pretty often. We use them for the baseline during the initial treatment. We use them again at each reexamination, and then again upon the conclusion of the treatment schedule. In addition to that, our patients are asked to rate their pain on the visual analog scale for each complaint at each visit. So, and that only takes seconds. It sounds like a lot, but it only takes just a minute. And yes, it's very subjective, exactly. It can have a wide variance from day to day for the same person, but when you're keeping these types of records, you're standing on more solid ground if anything about you or your treatment ever comes into question. Not to mention, it's just better for the patient to be kept track of in this manner. It's more specific. Here's a quasi-answer to a really big question. The question I'm referring to is, how often should I see a patient? Well, the full answer is not really in this paper, but there are hints at what they think. The researchers here, they suggest that a therapeutic trial of chiropractic is usually between 6 and 12 visits, and that should take anywhere from 2 to 4 weeks to complete. And that seems about the average. For further insight into generally accepted treatment protocols, you may also try looking at the Council on Chiropractic Guidelines and Practice Parameters. This is also known as CCGPP. So go and look that up. They've done a lot of work, and there's a great algorithm that you can follow should you choose. Next category, initial course of care for low back disorders. The best evidence of efficacy is with high velocity, low amplitude manipulation and immobilization. A good starting point in care is passive physiotherapy like electric stim, co-laser, ultrasound, things like that to help address the pain. Additionally, a practitioner should attempt to educate the patient about their complaint and set in place recommendations for self-management. As the authors state, physiotherapy shouldn't be used individually or isolated as the lone means of treatment. As I tell my patients, there is a mountain of evidence for manipulation and mobilization. a mountain of evidence for certain physiotherapies and a ton of evidence for exercise rehab. But the best evidence shows us that the greatest effectiveness comes from the three of those being combined and integrated into a treatment protocol that is reasonable and just makes sense. How it's used, it's going to come down to the practitioner's judgment and the patient's preference. What's working? What's effective? The authors here also state that they can't recommend the use of lumbar supports like bracing or taping because the research just isn't there to support it right now. Active care, otherwise known as exercise rehab, should become a bigger and bigger part of all chiropractic clinical protocols. I often will try to relate this to patients in a way that makes sense in a medical world. When appropriate, I may say something like, what happens on the day after someone has a knee replacement, appendectomy, or a C-section? What happens? They have them up walking, which may seem counterproductive to do so soon after a surgery. In fact, for low back pain, a common recommendation used to be to go home and get in bed and just wait it out. But they realized that movement is healing. Part of the healing is getting the joints moving properly through manipulation and joint mobilization, but that's just part of it. Another big aspect of it is exercise rehab, both here in the office and at home on your own. The more you explain why you want them performing exercise rehab, and the more you stress that exercise rehab is part of the protocol from the very start, the less resistance you tend to run into later down the road. Okay, next category, reexamination and reevaluation. So after your initial recommendations are fulfilled, well then what? Well, you need to determine whether any further treatment is indicated and why it's indicated. What was your patient's response to care? If you threw everything in your office, including the kitchen sink, at someone for 2 to 4 weeks for 6 to 12 visits, and you saw little to no improvement, do you think any further treatment is likely to bring about a positive change? Well, I would say not very likely. It's times like these that I swallow my pride, and in the best interest of the patient and in the best interest of my reputation, I find them a referral to a reputable practitioner that may be better suited to address the complaint. I wouldn't want a family member of mine treated any differently, so I don't treat my patients any differently. On the other hand, if the patient's complaint is resolved, you should perform a final exam and outcome assessment questionnaire. Make sure the patient is adequately educated on the recommendations going forward, like exercise, maintenance care, things like that, and then release the patient from the active care protocol. Okay, next category, benefit versus risk. The authors state that chiropractic care is remarkably safe and effective, certainly when compared to our medical counterparts. Even though we all know this already, it never hurts to restate the obvious, and I hope you don't mind. The paper says that serious adverse reactions to chiropractic care tend to only happen to the tune of about 1 in 1 million patient visits when referring to the treatment for low back pain. The authors went a little further by saying that while adverse reactions were very rare, other more mild to moderate events were noticed, like muscle soreness or stiffness. Of course, we see this in my office here and there as well. If they've never been to a chiropractor and then get sore after the first 1 or 2 visits, you could compare that to going to the gym after laying off for an extended time. You're doing something new and you're doing something different with the body than you have been doing. And it makes sense for people to get a little sore sometimes. I think that's pretty common sense. Okay, next category, contraindications and cautions. Have you always been completely aware and knowledgeable on what constitutes a hard contraindication to chiropractic care? The authors try to help us all out here a little bit, so listen up. This is a biggie, since I feel the importance of knowing these are paramount to your longevity in practice. I'm going to quote these conditions directly from the source for accuracy. Don't be caught having treated these conditions. General conditions like severe osteoporosis, multiple myeloma, osteomyelitis, local primary bone tumors where osseous integrity is questionable, local metastatic bone tumors, or Paget's disease. Neurological conditions like progressive or sudden neurological deficit, including cauda syndrome, or spinal cord tumors demonstrating neurological compromise, although care may be appropriate after specialist investigation and clearance. Inflammatory conditions like rheumatoid arthritis in active systemic stage, or locally in the presence of inflammation or atlantoaxial instability. The inflammatory phase of ankylosing spondylitis or psoriatic arthritis or Reader syndrome. Bleeding disorders like congenital or acquired or unstable aortic aneurysm. And they threw in another category such as structural instability, inadequate physical exam, or really bad adjusting training and skills. Okay, next category. Chronic pain management for spinal disorders. These conditions can no longer be referred to as acute or uncomplicated, as they are beyond the 3-month period at this point, and should be labeled as chronic. And other factors must be considered in a robust treatment protocol. Some complications may include work environment, and that would include ergonomics, work requirements, comorbidities, and some may wonder, well, what the heck is a comorbidity? Well, that is when you have 2 or more other conditions occurring in addition to the initial diagnosis. Low back pain in addition to arthritis and diabetes would be an example. Low back pain in addition to obesity and depression could be another. So the history of the condition's prior treatment is important. Keep in mind the lifestyle factors, including bad habits, other psychological factors, which may include depression, anxiety, and things of that nature. Whew, that's it. Well, that was a lot, right? With such an amount of information to wade through, I would say that Dr. Thistle did an excellent job of reviewing this paper for the American Chiropractic Association's blog. And I hope, in turn, that I've been able to bring even more clarity and maybe even relate it to my personal practice and your practice in a way that hopefully drives home the need for more regulation and practice standards in our profession. As the internet and the age of information has brought the world together, I believe that the days of being a lone wolf and or being an outlier, I believe those days may be numbered. When they say that ignorance is not a defense, that especially rings true these days now that information is at our very fingertips at all times of the day, no matter where we may be. You may agree with me that this is a good thing. You may disagree and think I'm off my rocker for wanting some standards in our profession, and that's okay. Differences in opinions, that's an American idea to the core. And usually what triumphs is reason, and if you find these guidelines or those of the CCGPP to be reasonable guides, I hope you consider giving them more thought, maybe even implement them into your regular treatment protocols. Regardless of how you go about practicing, I'm a firm believer that we chiropractors can absolutely change the world when it comes to the treatment of non-complicated neuromusculoskeletal conditions of the body. Not just low back pain either, but the whole shebang. As I said last week, if we were wrong in what we do as a profession, we would have been wiped off the face of the planet years ago. Lord knows they tried, and they keep trying. The Texas Medical Association is suing Texas chiropractors right now. But we're still here because we are naturally right. But we give our detractors ammunition for the battle when we're not holding ourselves and our profession to certain reasonable and responsible standards. When chiropractic is at its best, you cannot beat the risk versus reward ratio. You cannot beat it, plain and simple. Spinal pain is a mechanical pain, and it responds better to mechanical treatment rather than chemical treatment like painkillers, muscle relaxants, and anti-inflammatories. It's a fact. And it's just another reason to call a chiropractor today. Research and clinical experience shows that in about 80 to 90% of headaches, neck and low back pain in comparison to the traditional medical model, patients get good or excellent results with chiropractic. It's safe, it's more cost effective, it decreases your chances of having surgery, and it reduces your chances of becoming disabled. We do this conservatively and we do it non-surgically. In addition, we can do it with minimal time requirements and minimal hassle on the part of the patient. And if the patient develops a preventative mindset going forward from initial recovery, we can usually keep it that way while raising the general overall level of health. Please feel free to leave me a comment. Tell me your thoughts. I'd love to hear what you think. And remember, sharing is caring. Share, share, share. We can't make a difference without your help. Be sure to find us on social media sites like Facebook, Twitter, Google+, Pinterest, LinkedIn, Snapchat, and Instagram. Also be sure to subscribe to our YouTube channel. The link is in the description, or just hit the big, huge subscribe button right below. At the very least, can we just talk you into giving us a thumbs up? A gesture that simple and quick on this video really helps us to get in front of more people looking for this kind of information. Now be on the lookout for our new podcast called Chiropractic Forward. It's up and running. Every new episode will come out on Thursdays. So be on the lookout for those. I believe there's already 3 episodes going. We got our 4th episode will be up this Thursday. In the meantime, you can get more research-related blogs at amarellachiropractor.com/blog. Till next time, thanks for watching, and we'll see you next week.